A 20-year-old man, let's call him Brandon, is serving a 6-month jail sentence for violating probation when he starts to hear voices that others cannot hear. He looks around suspiciously, talks back to these voices, isolates from others, and becomes very fearful of the corrections officers. When an officer approaches him for a check-in, he becomes frightened and agitated. He's yelling for help because he fears for his life. The officers restrain the psychotic young man and take him to seclusion, where he is stripped of his clothing and put into a smock, and he is now considered to be a safety risk. He spends 3 days in a frightened and confused state. He is treated with sedating antipsychotic medications and transferred back to general population. But he has no regular access to mental health treatment for proper follow-up, and he starts having side effects from his medications. He refuses those medications, and a week later starts hearing voices again. He isolates and becomes fearful of the officers. He's agitated, and an officer approaches him. And the cycle continues.
Schizophrenia and bipolar disorder strike people in the prime of their lives, in their teens and their 20s. These individuals will be tormented by hallucinations, delusions, and cognitive difficulties. Many will not lead fulfilling lives in terms of finishing college, having gainful employment, or starting a family. 1 in 10 will successfully commit suicide. I'm a physician scientist at Harvard Medical School. In my clinical role, I specialize in the treatment of patients with schizophrenia and bipolar disorder. We know what leads to good outcomes: specialized intensive treatment in the early stages of the illness. Many of my patients have gone on to graduate from college and some from graduate school. One of my patients is now a doctor and another is a nurse. We know from our experience and from extensive research that early intervention is critical for a favorable outcome. However, these patients often get into trouble with the law when they're having psychotic episodes. When they're paranoid and agitated, hearing ominous voices, they're not thinking in their right mind, and they end up doing things that result in them getting arrested. This has happened to my patients. When a patient gets arrested, I no longer have contact with him or her, and he or she will usually come out of jail in a much worse condition. Depending on how long a patient is incarcerated, we may have lost a critical window for intervention that could have changed the trajectory of their illness and of their lives.
I am a clinical social worker working with young people who have psychosis. I've spent my career working with patients in the jail and the hospital settings. 2 different settings, same diagnosis, and a large disparity in the standard of care. In jail, patients are only seen during the acute phase of their illness with poor follow-up, no individualized care, and when they are released, they often leave with no follow-up services. The clinicians are often overwhelmed with the high number of inmates on their caseloads, and those most in need, they fall through the cracks. In the hospital, patients receive a personalized approach with an assigned treatment team with 24-hour care. Focus is on optimizing the medication. The case manager focuses on psychosocial stressors and family support, and a comprehensive aftercare plan is developed. There is a large gap in providing optimal care. Our goal has been to bring the hospital standard of care into the jail.
The mental health system and the correctional system are 2 major institutions in our society, but there is no regular interaction and engagement between those 2 systems. For many patients with mental illness, jail has become a revolving door with recidivism and reincarceration due to their mental illness. The National Alliance for Mental Illness reports that 2 million people with mental illness are imprisoned each year. The prevalence of psychosis in particular is 10 times higher in the correctional settings than in the general population. And minority patients with psychotic disorders are incarcerated at a higher rate. We wanted to address this gap by forging a partnership between our hospital and our county jail. We wanted to foster crosstalk and collaboration with the intention of bringing evidence-based treatment to these young adults in jail. When we started, there was a steep learning curve. While there was a lot of enthusiasm in the sheriff's office and the jail leadership, there was also a healthy skepticism about clinicians from an academic psychiatric hospital coming to work in the county jail. There were regulatory and bureaucratic hurdles that meant we could not actively treat patients in the jail when we started. So in the beginning, we decided to get our feet wet and learn about the jail system through our presence and through our interactions.
So we partnered with leadership at our local county jail to develop a treatment-focused model aimed at early intervention with inmates who have psychosis. And to begin our services in the jail, we facilitated weekly group sessions in the young adults unit, focusing on psychoeducation, providing coping skills, expressive writing groups, and mindfulness meditation. We built trusting relationships with the corrections officers and the clinical staff in the jail. We then convened a strategic planning session that included the leadership and key staff from both institutions to explore how a collaborative partnership might be formed to better serve the mental health needs of inmates. And from that workshop, we developed a working proposal for a treatment-focused mental health unit in the jail, staffed by clinicians from the hospital to provide programming, psychiatric treatment, and aftercare planning to inmates.
We had enthusiasm and interest from committed clinicians, the correctional staff, and the jail leadership. Yet, despite our best efforts, our plan did not come to fruition. This was a wicked problem with many layers of obstacles. For instance, the HR department in the hospital said that we could not have mental health staff from our hospital work in the jail due to labor laws related to unions. The administrators in the hospital told us that there were regulatory restrictions for physicians employed by the hospital, that they cannot work in facilities that are not licensed by the Department of Public Health. The jail falls under the Department of Corrections, so we would not be able to provide clinical care there. There was a paucity of funds to undertake this program. While the jail officials went out of their way to come up with resources, there was not enough at the end to run a small pilot program. We have learned that having committed people on the ground who provide direct care is not enough to tackle a problem that involves entrenched institutions with different goals, priorities, and cultures. We have to get buy-in from important stakeholders who can help us navigate the can't do it mentality that we often encounter with the bureaucrats. We have not given up. We will continue to explore avenues to tackle this wicked problem. How can we negotiate the maze of bureaucratic and regulatory hurdles? How can we find the necessary resources and have leverage with those who control the purse strings? We'll continue to expand our horizons and engage with those beyond our usual institutional structures to think outside of the box and explore new paths to address this problem. These young adults deserve the treatment that can change the trajectory of the illness and lead meaningful lives with less pain and suffering.